Hi, welcome to the third lecture in the basic science part of the orthopedic board, and in this one we're going to speak about research. A good source that you can use for studying in your board is this book written by myself. First, we'd like to speak about level of evidence of studies. Level of evidence of studies, it's important because it tells you how strong is the conclusion that you can get from this study. It goes from level 1 evidence, which means the strongest evidence, to level 5, which is the weakest evidence. Level 1 evidence is well-designed, multi-center, randomized control studies. So it has to be a well-designed study. It cannot have some major flaws in the design, and it has to be randomized. So the patients should be randomized to the treatment options. Another option of level 1 evidence is meta-analysis of level 1 randomized studies. So level 1 evidence, this is the highest evidence. It's well-designed, multi-center, randomized control studies, mean that the patients are randomized to the treatment options, and it's well-designed so it cannot have major flaws. Or it can be meta-analysis of level 1 randomized studies. Level 2 evidence, if you have a randomized control studies but with some flaws in the design, or if you have a prospective non-randomized comparative studies. So if you have a randomized control studies with flaws in the design, or if you have a prospective non-randomized comparative studies, so it means that the patient are not randomized to the treatment option. Level 3 evidence, most of the studies that we use is level 3 evidence. These are retrospective case control studies. So you have two treatment options, for example, and you study them retrospectively, that's a level 2. If you study them prospectively and they are not randomized, that's level 2. So level 3 is a retrospective case control studies. It means that you have two treatment options and you study them retrospectively, that's level 3. If you study them prospectively without randomizations, that's level 2. Level 4 is a case series, like you describe the treatment option in like 15 patients without comparative group. This is cases series. Level 5 is expert opinion. So 1, highest level, it's well designed, multi-center, randomized control studies. Patients are randomized to the treatment options, or it can be meta-analysis of level 1 randomized studies. Level 2 evidence is randomized control studies but have some flaws in the design, or prospective non-randomized comparative studies. Level 3, there are many of the studies that we use are level 3. These are retrospective studies of a case control groups. If there is no case control group, it's only case series, that's level 4. If it's an expert opinion, that's level 5. So these are the level of evidence. 1, remember, is a well-designed randomized control studies or meta-analysis of these studies. 2, randomized control with some flaws or prospective non-randomized. 3, retrospective case control. 4, case series, no comparison. 5 is expert opinion. We spoke about if there is flaws in the design, which another word for it is bias. So what is bias is systematic deviation from the true outcome. So there is some flaws that will cause the result to deviate from the true outcome. This is bias. How to limit bias in clinical research? 3 main things: randomization, concealment of allocation, and blinding. Randomization means that the patient are randomized to the treatment options. Concealment of allocation and blinding, these are not the same. Concealment of allocations meaning that the person who allocate the patient to the treatment option does not know which direction will go the next patient. So he doesn't know this next patient or the patient in front of him will go either to the treatment group A or B. That's called concealment of allocation. And blinding is, there's two types of blinding: single blinded, when the patient does not know which treatment group he's in; double blinded, when the patient and the treating physician does not know the treatment group. So blinding is not concealment of allocation. Blinding is when the patient in single blinded does not know which treatment group, and double blinded, the patient and the treatment physician does not know which treatment group. But concealment of allocation, the person which is responsible for allocating patient to the treatment group does not know the next case which treatment group it will go for. The best concealment is to stay away from the treating physician. So the best concealment method is either computer-based selection or opaque envelope that tells you if it's treatment option, for example, A or B. The most important thing in concealment of allocation is to keep the treating physician away from the selection process. Physician-driven outcome, like return for surgery, for example, this is major source of bias in any studies. And to reduce this, if you have this outcome, the patient-driven outcome in any studies, you have to have a strict criteria for the intervention, and these should be determined before conducting the study. What are the types of studies? We have meta-analysis. Meta-analysis is systematic review in which you analyze the results of independent studies studying the same object. For example, let's say that you have multiple studies about DVT after total hip. So you do meta-analysis by combining the results of these studies. Usually the studies that are used are randomized clinical studies, and usually to do this you need sophisticated statistical methodology. There is something called observational studies. In the observational study, the investigator does not interfere. He just observe the finding. So this can be, for example, prevalence rate, risk factor, prognosis of a condition. One type of observational study called cohort study, in which the investigator study group of individual over a period of time. So if there is a group of individual over a period of time, it's called cohort study. So cohort study is type of observational study. Experimental studies, in this type of studies, the investigator actually interfere and does something into the population. So it's a prospective study. It has always to be prospective. Randomized clinical trials are type of experimental studies. In the cases of randomized clinical trials, as we discussed before, the patients or the individual will be divided into groups using some sort of randomization. Last type that we would like to mention is the case control studies. In cases of case control studies, the population is divided into cases and controlled based on the presence or absence of a disease or an outcome, and these are always retrospective. There are two types of randomized clinical trial design. One design is called the parallel design, and this is the one which is mainly used in orthopedic, in which you have two groups. For example, group A and group A will receive certain treatment, and group B will receive another treatment with no crossover between the two groups. This is parallel design. This is the design that is mainly used in orthopedic. A crossover design, this is a different type of design in which all patients in group A, for example, will receive two treatment options, and then in the group B they will receive the same treatment option but in different order. So for example, if you have group A, it will receive treatment X, then treatment Y, and then you will have another group, group B, that will receive treatment Y and then treatment X. This is not used mainly in orthopedic. It may be used like for to compare between two medications, and it has the advantage that patient can be their own control. So you don't have to have a different control. The patient can be the control of themselves. So the parallel design, this is the one that is mainly used in orthopedic, in which, for example, you have two treatment groups. Each group will have a different treatment option, and there is no crossover between them. The crossover design, you have, for example, two groups, and each of them will have the two treatment option, but in different order. Let's talk about outcome measures, which is used in orthopedic research. Let's start about with the form 36, short form 36. The short form 36 is commonly used in musculoskeletal research. It assesses the musculoskeletal function. It's a patient-derived assessment. It means that the patient will fill the form, so it's self-reported, self-administrated. It requires minimal amount of resources. As we said, the patient is the one who filled the form. He's the one who is going to report his function.
The problem with the short form 36, it has the potential for seal and floor effect. What does this mean? Sealing effect, it means that the outcome may not be able to differentiate between two good results, which one of them is better. The floor effect is that the outcome may not be able to differentiate between two bad results, which one of them is worse. There is another outcome measure that is commonly used now, which is called the PROMIS. It's the abbreviation of Patient Reported Outcome Measured Information System, and this one uses technology and computer technology to get to the assessment with less number of questions. So, for example, it will not ask every patient how much do you walk, how long can you stand, and how much can you run. It will, for example, it will ask you how much can you walk, and if you answer that you can walk for 2 hours, it will ask you how much do you run. But if you say for the first question I cannot walk, it will not ask you how much do you run because you cannot walk. So it will ask you a question, how long can you stand? And in a similar fashion, it can get better assessment in lower number of questions. So the PROMIS, it started to be commonly used now, and it can get better assessment, so it's less ceiling and floor effect with lower number of questions. Now let's talk about IRB, or the Institutional Review Board. The IRB function is to ensure the safety of the human subject in any research. So in other words, the IRB function is to ensure to maximize benefit and minimize risk in case of research on human subjects. So if you have a research that you're doing, the IRB function is to ensure the safety of the human subject. In another word, maximize benefit, minimize risk. If the investigator is doing a project for quality improvement, let's say, for example, you're studying the rate of infection in total hip because you would like to decrease that rate and improve the performance in your hospital, and you're not planning to publish that in any journal, you don't need to get an IRB approval. So quality improvement project does not need to get an IRB because it's not considered research. If one of the investigator has a conflict of interest, this is not a contraindication to carry out the research. What you have to do is you have to disclose. So this is the word that you have to remember. It is disclose. The researchers need to disclose any conflict of interest. So remember, a conflict of interest is not contraindication for research, but you need to disclose. So the word is disclosure. There is difference between the IRB and the DSMB, the Data and Safety Monitoring Board. So the IRB will give the approval. So the IRB will look into the protocol, will make sure that the research is safe, and then give the approval. What is going to monitor the project after that is the Data and Safety Monitoring Board, the DSMP, and this board will follow the study and see if there assess if there is any adverse effect that is related to the treatment option. So the principal investigator, if he notices that there is any adverse effect, he should report that to the DSMB. The DSMB after that can communicate with the IRB. So remember, the IRB study the protocol and give the approval before the research starts. After the research starts, what monitor the adverse effect is the DSMB, the Data and the Data and Safety Monitoring Board. It is the one that assess continuous assessment of the study during the study time. So before is the IRB gives the approval. Once the study starts, what assess the adverse effects related to the treatment is the Data and Safety Monitoring Board, and the principal investigator should be reporting any adverse event to the DSMB. Now let's talk about statistics, some of the questions that can come in your exam related to statistics. Confidence interval. Confidence interval is the range of values that is most likely to include the unknown variable that you're studying. So 95% confidence interval, this is what we usually measure, report. 95% confidence interval is the range of values that is 95% going to have the true value of the variable that we are measuring. So when you say that the 95% confidence interval from 2 to 3, so that means that you're 95% certain that the value that you're studying will fall between 2 and 3. If you are reporting confidence interval for a relative risk and the confidence interval crosses 1, this means it's non-significant relation. So if your confidence interval from 0.8 to 1.4, so this range has 1 in it because it goes from 0.8 to 1.4, so that means that the relative risk can be 1, which means that the thing that you're studying is really not a risk factor. So if you have a 95% confidence interval for relative risk that crosses 1, it means it's non-significant risk. Let's talk about type 1 and type 2 errors. I know that this is a very tough topic and lots of orthopedic surgeons may not really understand this. So I'm going to explain it in a way to make it simple for the people who are planning to take the exam. So type 1 and type 2 error. We're going to speak about type 1 and type 2. Before we speak about type 1 and type 2, I'd like to tell you what exactly is the null hypothesis. So whenever you have a study, you have a hypothesis and null hypothesis. So let's say that your hypothesis is treatment A is better than treatment B. So this is your hypothesis. Treatment A is better than treatment B. Your null hypothesis will be treatment A and treatment B will be the same. There is no difference. So if your hypothesis is A is better than B, your null hypothesis will say that both treatment options are the same and no one is better than the other. In any study, when you reach a conclusion, you will say that my hypothesis was correct. If let's say that you do a study and you find really that A is better than B. In this case, you will say at the end that my hypothesis was correct and A is better than B. Or you can say that I can reject the null hypothesis. Like the null hypothesis, which says A and B are the same, I'm going to reject it because it's not correct. So again, this is very important. So your study says my hypothesis is A better than B. So null hypothesis will be A and B are equal. You do your study and then you find that A is better than B. So in this case you will say, my hypothesis was correct. Or you can say, I reject the null hypothesis. You can say, I reject the null hypothesis. So let's talk now about type 1 and type 2 error. Okay. So let's say that, so make it here, we'll say A is better than B, okay? This is your research. You found that A is better than B. So type 1 error, here, this is type 1 error, is when you have a false positive. So what does this mean? Means that actually type A and treatment A and treatment B were the same and your results were wrong. So treatment A and treatment B were actually the same. No one was better than anyone, but your study was wrong. It showed you that A is better than B. So your study was wrong. So you rejected the null hypothesis. You have rejected the null hypothesis at the end of your study, but you were wrong. So you have type 1 error. So type 1 error is false positive. So you are, as a researcher, you told us that treatment A is better than treatment B. That was false positive, or in another word, type 1 error. So when you reject the null hypothesis, when the null hypothesis was correct, because in reality treatment A and treatment B were actually the same and your result was wrong, so this is the scenario that leads you to type 1 error. So again, the scenario is a researcher study A and B treatment option. His hypothesis that A is better than B. So his null hypothesis is A and B are equal. His research end finding A better than B. And this was actually a wrong result. Was a wrong result. A and B were equal treatment option, but his study was wrong. There were some bias and he ended with wrong study and wrong result. So what he did at the end of his study, he accepted it as a hypothesis and he rejected the null hypothesis. So this scenario gets you to type 1 error. So when you reject a null hypothesis when it's actually true, this is type 1 error, which means it's false positive. The researchers told us that A is better than B, which was false positive. Okay, false difference. The difference that he found was false. It was not true. Let's say and give another scenario. So again, hypothesis was treatment is better than B. So the null hypothesis A and B are the same. The researcher does the study and he found both are equal. But in reality, A was actually better than B. So your hypothesis that A is better than B, your null hypothesis both are the same. You do the study, you find them the same, but your study was wrong. Because actually A was actually better than B, but you could not find that difference. So this is type 2 error. This scenario will take you to type 2 error. It means false negative. So the researchers told us both treatments are the same, A and B are the same. I'm going to accept the null hypothesis, but the null hypothesis was wrong. That ends you in type 2 error. So again, the second scenario, the researchers found A equal to B, which is not correct. Actually, A is better than B. So his hypothesis was A is better than B. The null hypothesis A and B are the same. He does the study, he found A and B are the same, which is not correct because actually A is better than B, but his study was done wrong. So at the end of the study, he says, I'm going to accept the null hypothesis, or I'm not going to reject the null hypothesis. I'm going to accept the null hypothesis. I'm not going to reject it, while the null hypothesis was false. So the null hypothesis said the A and B are equal when actually A was better than B. So this is type 2 errors. This is false negative. He couldn't find a difference, but there was actually a difference. So type 1 error, which we sometimes call false positive, when you reject a null hypothesis that is actually true. Type 2, when you actually accept a null hypothesis or not reject a null hypothesis when it's actually false. So this is type 1 and type 2 error. Of course, if you have a null hypothesis that is true and you accept it, that's a correct outcome. So this is the example. For example, a researcher says that A is better than B. My null hypothesis is A and B are equal. He does the study. He found A and B are equal, and in reality they are equal. So he will accept the null hypothesis. So this is a true outcome. If he says A is better than B, this is the hypothesis here, and the null hypothesis A and B are equal. He does the study, he found A is better than B, and actually A is better than B, so he's going to reject the null hypothesis, which is correct because the A is better than B, so this will give you a correct outcome. So these are the 4 scenarios for hypothesis and null hypothesis, and accepting and rejecting the null hypothesis, and type 1 and type 2 error. So type 1 error, when the researcher find a false difference. So false difference, this is a type 1 error. Type 2 error, when the researchers fail to find difference when actually the difference is true. Now let's talk about p-value. We usually found the p-value in the studies that we read. So what is the p-value? P-value is the probability of type 1 error. We describe type 1 error, sometimes referred to as alpha error, extensively in the previous slide. We said type 1 error is the false positive, meaning that you reject a null hypothesis which is actually true. In another word, the researcher says that there is difference between the 2 treatment group, for example, when actually the observed difference was by chance. It was not a true difference. So this is type 1 error. The probability of this type 1 error is the p-value. So the p-value is usually related to the significance, the statistical significance. Usually, if you measure the p-value, which is the probability of the type 1 error, and you find it less than a certain number, you can reject the null hypothesis. This number is arbitrary number, so we decide on this number. Usually it's 0.5 or 0.1. It depends. Some studies will use this, some study will use this. It's a predetermined arbitrary number that people decide on. So you measure the p-value, which is the probability of the type 1 error that we discussed before. If it's less than a certain value, which is usually 0.5, you will say that there is a difference and I can reject the null hypothesis. So I can reject the null hypothesis because the probability of having an alpha error is very small, which is less than 0.05, so I can reject the null hypothesis now. So this is the p-value. It is the probability of type 1 error, and if it's less than certain number, you can reject the null hypothesis. So let's continue with the p-value. So we said p-value usually less than 0.5 will tell you that you can reject the null hypothesis, and you can announce this result as statistically significant, and the difference that you found is a real difference. So when you have a p-value less than a certain number, usually this number is 0.5, you have very low probability of having type 1 error or alpha error. So you can say, okay, because this is low probability that I'm having that type of error, which is type 1, I'm going to reject the null hypothesis and I'm going to accept my hypothesis. So this number usually is the 0.5, indicate that the result has a high probability that the difference that you found is not by chance. It is not type 1 error. So you found the difference between A and B, and you measure the p-value of that difference. You found it 0.1, for example. So the 0.1 is less than 0.5. So the chance of having type 1 error, the alpha error, the chance that the difference that you found between type A and type B was not real, is very low. So you can say, okay, I'm going now to reject the null hypothesis and I'm going to accept my hypothesis. So this is the p-value. Remember, the p-value does not establish any clinical significance. It can say that this difference is of statistical significance, but it does not tell you anything about clinical significance of what you found or the importance of the difference. So p-value can tell you that the difference is statistically significant, but it cannot tell you any clinical significance or any importance of the result. Okay? What is the meaning of fragile p-value? With a small sample size, a change of one variable from group A, for example, to group B will move the p-value from 0.1 to 0.3, for example. So this one value only changed the p-value significantly. We call that small fragile p-value. Usually this happens with a small sample size. So the treatment or the solution for the fragile p-value is to increase the sample size. After we talk about p-value, let's talk about the power. So the p-value was dealing with type 1 error, as we discussed. The power deals with type 2 error. So let's review what is type 2. Type 2, if the researcher says that treatment A and treatment B are equal, where actually one of them is better than the other. So type B error is when you decide that there is no difference and actually there is a difference, or what we sometimes call it is accepting the null hypothesis when it's actually the null hypothesis was wrong. So there was actually difference and you said in your study that there is no difference. So this is type 2 error. The power deal with type 2. So the power is the ability to find a difference between two groups or various groups that actually have difference between them. So you're studying, for example, two groups, treatment option, and there is actually difference. One of them is better, and you want to have your ability to find that difference is the power. So the power, in other words, is 1 minus the probability of the beta error. So usually we would like to keep that power at least 80%. So let's review that. So you're studying, for example, two groups, treatment A and treatment B. Actually, treatment A is better than treatment B. So you want to have a good probability that your study will show that treatment A is better than treatment B, because this is actually the reality. Treatment A is better than treatment B, and you want to have a study that will show that. So you want to have a high probability of discovering that. So usually we design the studies to get at least probability 80%. So what does this 80% mean? Means that you have only 20% chance of type 2 error, or what's sometimes referred to as beta error. So when you design a study, you want at least 80% power, meaning that the probability of type 2 error, which is accepting a null hypothesis that is wrong, or saying that there is no difference when there is a difference, is only 20%. So the probability of beta is 20. If the probability of beta is 20%, your power is 80%, and that should be a good study. So good study is the study that has power of at least 80%. If it's 90%, it's better, but you want it at least 80%. What does this 80% mean? Mean that you have 20% chance of beta error. Beta error is the false negative, that you say, oh, the treatment of A and B are similar, while actually A is better than B. So it is accepting a null hypothesis that is actually wrong. So this is the power. It is 1 minus the probability of beta error, and you use the power to calculate the minimal sample size. So the power is something that we decide on. Let's say that you want a power of 80%, and then you put the p-value, usually 0.05, and then you run some statistical equations, and you get a number of the sample size that you need to have an 80%. So the probability will allow you to measure the minimum number that is needed to achieve the 80%, or of course if you want to do 90%, the 80% or the 90% chance that you will discover a true difference. So you can use that 80% or 90% to calculate the sample size that will give you 80 or 90% chance of discovering the difference, or in another word, 10 or 20% probability of beta error. Let's continue with the power. As we said, power is the probability of finding a difference when it actually exists. So it is 1 minus the beta error. So what are the factors that goes into the power? The sample size, this is very important. The type 1 error rate, which is the probability of the type 1, the p-value. The standard deviation of the thing that you're measuring. So for example, you're measuring the number of the bacteria after the antibiotic, for example. So what is the standard deviation? And the effect size of the variable. So you won't like, for example, to say, oh, antibiotic A will result in 20% less number of bacteria. So you want to know the standard deviation of the thing that you're measuring, which is like the number of the colonies. And the effect size, you want, like for example, a 20% better antibiotic, and of course the p-value, which you can decide on 0.5 or 0.1, whatever you decide on, and the sample size. In most cases, actually, we use the sample size we calculate the sample size, so we know all the other variable, and we would like to get the sample size. So we will decide, let's say, or to get a power of 80 or power of 90, and I have the type 1 error, I have the standard deviation, I have the effect size. What is the sample size? So these are the factors that affect the power, but in most cases the power is predetermined thing. You want a power of 90%. So what is the sample size that will give me the 90%? So in most cases, we don't need to measure the power, because we actually decide on the power. We decide on 80 or 90, but we want to measure the sample size. Now let's talk about some of the statistical tests that sometimes comes in the exam for categorical data. Categorical data is like male or female, or presence or absence of a parameter. These are compared statistically using the chi-square test. If you think that the sample size will be small, you can use the Fisher exact test. So in general, it's the chi-square test, but for small sample size, you can use Fisher test. The parametric variables, they are either use the student t-test or the ANOVA. The student t-test, if you are comparing two means.
If you are going to compare more than two, then use the analysis of variance or the ANOVA. Okay, so categorical data is chi-square unless the sample size is small, use Fisher exact. Parametric variables like the average height, average weight, all these things, if it's two, you use the student t-test. If it's more, you use the ANOVA. The Kaplan-Meier is used to analyze the survivorship of a subject or a product, like it's used commonly, for example, total hip survivor or total knee survivor. This is the Kaplan-Meier analysis. The linear regression analysis is used to assess the relation between dependent variable and one or more independent variable. So you want to see the relation between some sort of thing that you study, for example, bad outcome, and then you want to see what are the reasons of that can be associated with this bad outcome. So you use the linear regression analysis. Let's talk about the difference between the incidence and prevalence. The prevalence is the number of all cases. So all cases, this will be considered the prevalence of disease at a one point of time. So if you say, for example, that the prevalence of diabetes is 30 cases per 100. So that means if you get 100 people and you test them, you will find 30 of them has diabetes. So it's the number of all cases, whether old or new. The incidence is different. The incidence measures the number of new cases over a certain period of time. So for example, it can be 1 year, 1 month, or a decade. Usually it is a year. So if you say that the incidence of diabetes is 1 per 100 individual per a year, it means that if you have 100 individual and then you follow them for 1 year, you will find one of them will develop a diabetes. So you start with the people that don't have the disease, and then you follow them for a certain amount of time, and then how many new cases you will get. So this is the incidence. So it's the number of new cases per over a certain period of time. So incidence, number of new cases over a certain period of time. Prevalence is the number of all cases at one given time. For you to assess the incidence, you have to do a cohort study in which you follow a group of individuals for over a period of time. So it has to be a prospective study. So it has to be a prospective study. You will follow a cohort of individuals over a certain period of time, and you will see how many new cases will develop. And it gives you a measure of the risk of developing new cases. Now let's talk about odds ratio and relative risk and explain the difference between them. Both of them are similar in a way that they describe or assess the relation between certain risk factors and end outcome. Usually we use the relative risk for prospective cohort study and the odds ratio for case control retrospective studies. So both odds ratio and relative risk, they are used to assess the relation of certain risk factor to end outcome or end result. Usually the relative risk is used for prospective cohort studies, and the odds ratio are used in case control retrospective studies. What is odds ratio? Odds ratio is, as its name says, of course, is the ratio between two odds. So what is odds? The odds is probability of an event divided by the probability of non-event. So this is the odds. So it is the probability of an event divided by the probability of no event. We're going to describe this on the table here. So like the odds with the presence of risk factor, which will be the event A divided by the non-event B. So it will be A over B. The odds with no risk factor will be C over D. So if you want to have the odds ratio, it will be A divided by B in relation to C divided by D. So it will look like this: A divided by B, the relationship, or divided by C divided over D. So this is the odds ratio. It is the relation between two odds, A divided by B and C divided by D. So this is the odds ratio. The relative risk, the risk is the risk is the probability of an event in a group. So here it will be A divided by A plus B. So it is the probability of the event in the whole group. So in this case, if you have a risk factor, it will be A divided by A plus B. And if there is no risk factor, it will be C divided by C plus D. So the odd is the relation, the odds is the probability of an event divided by the probability of no event. So it will be A or divided by B, or C divided by D. And then you get the ratio of these two. The risk factor is the risk in general is the probability of an event in a group. So it will be A divided by the whole group, and it will be C divided by the whole group, C plus D. So let's make an example to make it easy. So for example, if you have an event which is failure in the exam. So this is an event, and the no event, of course, will be not failure. The risk factor, let's say, is like too much use of a social media. So this is a risk factor. And you would like to assess the risk factor to the event. So you want to see what is the risk factor of the event, which is the failure of the exam, with the risk factor which is too much social media. So in this case, for example, if you want to use the odds ratio, let's say that you have here 10 students that have too much social media. 4 of them had failure and 6 of them passed the exam. So in this case, the odds of failure in case of too much social media will be 4 divided by 6. And in this case, if you don't have too much social media, let's say that you have 10 students with no much social media, one of them only failed the exam and 9 passed. So the odds of the event, the failure, will be 1 over 9. So if you want to have the now the odds ratio, it will be 4 divided by 6, which is about 2/3, and then divided by 1 over 1 divided by 9. So if you do the calculation, it will be around 4. So in this case, the odds ratio, it will be 6. The odds ratio in this case will be 6. So the odds ratio, it will be here, the students that failed the exam with too much social media, we said 4, and then here will be 6 that has no event, and then over the no risk factor, it will be here only one student that has this, and 9, so the 9 will go up here, so it will be 4 by 9, that's 36, divided by 6, it will be 6. So the odds ratio for this calculation will be 6. Let's say that you wanted to measure the relative risk. In this case, the relative risk, as we said, the risk is the probability of an event in the group. So the risk of failure with too much social media will be 40%, because you have 10 students, 4 of them failed, and then with no social media, it will be 10%. So if you want to have the relative risk, it will be 40% divided by 10%, it will be 4. So in this example, that you have 10 students with too much social media, 4 of them failed, 6 of them passed, 10 without social media, 1 of them failed, and 9 of them passed. The odds ratio is 6 and relative risk is 4. So as you see, there is difference between relative risk and odds ratio. However, if you have very, very large group B and D and very small A and C, usually the two numbers will become very, very close to each other. So if the A is very small and the B is very big, that number will be very close to that number. So A plus B will be close to B, because A is very small and B is very big. So if you have a study that is done over thousands or millions of people, and the event that happens is not as common, for example, cancer development, relative risk and odds ratio will become very, very close to each other. The last part of this lecture is going to speak about assessment of tests that are done for disease. So we're going to talk about sensitivity, specificity, and false and negative predictive values. We are going to use this table to describe the sensitivity, specificity, positive and negative predictive value. So this column here is individual who have the disease. This column for individual who do not have the disease. This row is for individual who have positive result, and this row for the people who have negative result. So here A is the true positive, so they have the disease and the test show that they have positive result. C here is the false negative, meaning that they have the disease but the test shows that they don't, they are negative, they don't have the disease, so it's false negative. Here, this column, as we said, there's no disease. The B here, this group is people who the test shows that they are positive despite that they don't have the disease, so it's false positive. And this is people who don't have the disease and the test shows them as negative. So these are the true negative and the true positive. Here is the false positive and false negative. So A, people who have the disease and positive, that's true positive. D, people who don't have the disease and negative, so they are true negative. C is the false negative, they have the disease but the test shows them as negative. B is false positive, they don't have the disease but the test shows them as positive. So this is the table that we showed in the previous slide. So let's start with the sensitivity. What is the sensitivity? Sensitivity is the proportion of the people who have the disease and showed by the test as having the disease to the whole people with the disorder. So it is the true positive divided by the whole people who have the disease, which is the true positive plus false negative. So sensitivity is A divided by A plus C. So it is the true positive, the proportion of the true positive to the whole population who have the disease, which is A plus C. So sensitivity is A, true positive, divided by A plus C. So if you have a very low C, that will make the A divided by A plus C close to 100%. So the highly sensitive tests are tests who have a low false negative. Highly sensitive tests are tests who have low false negative, because you would like to make the A divided by A plus C. If you have a low C, that means that this will be a large number. And in general, when you're doing a screening test, you'd like to get tests that are highly sensitive. So sensitivity again is the proportion of the individual who have the disorders and shown by the disease to be positive in comparison to the whole population of the diseased person. So it is the proportion of A to A plus C. You want to have low C to have a highly sensitive test. If you're doing a screening test, you'd like to get highly sensitive test. So let's talk now about specificity. Specificity of the test is the proportion of the people who don't have a disease and shown by the test to be free of the disease to the whole population of non-diseased individual. So in other words, it is D divided by D plus B. So if you have a low false positive, that will be a very specific test, or the specificity will be high. So as we said, the specificity is D divided by D plus B. So if the B is low number, this equation will give you a number close to 100%. If you want to do a confirmatory test, you would like to get a highly specific test. So quickly, sensitivity is assessment of the false negative. Specificity is assessment of false positive. So highly sensitive tests have low false negative. Highly specific test has low false positive. If screening test should be highly sensitive, confirmatory test should be highly specific. The sensitivity assess the people who are true positive to the whole diseased person. The specificity assess the true negative to all non-diseased individual. So these are the specificity and sensitivity of the test. The other two parameters that we measure are the positive and negative predictive value. The positive predictive value, it measures the individual who have the disease and test positive. In another word, the true positive to everyone that tests positive, which is a true positive and false positive. So positive predictive value is A divided by A plus B. It is the individual who have true positive to everyone who tests positive. The negative predictive value is the proportion of the people who are free from the disease and test negative to everyone who tests negative. So it is D divided by C plus D. So positive predictive value is the true positive to everyone positive. So A divided by A plus B. Negative predictive value, true negative, which is D, to every negative, which is D plus C. Positive and negative predictive value are affected by the prevalence of the disease. So specificity and sensitivity, they are not affected, but positive and negative predictive value are affected by the prevalence of the disease. Thank you for listening to this lecture.